Hello, everyone. I'm Sherry with the CGH Health Foundation, and welcome back to another one of our Growing Healthier programs. These programs are done every month on Facebook Live, and it's a way for us to provide some education and also introduce you to some of our excellent healthcare providers. And today's no exception. We have two of our cardiologists. At CGH, we provide excellent cardiac care, and we continue to expand our services. So today, Dr. Bird is going to be visiting with Dr. Rashid, who sees patients in our Morrison Clinic, and with Dr. Kiso, who is seeing patients in our Dixon Clinic. They're going to talk about all of our cardiology services and some new treatments and innovations in caring for our hearts. Before I give it over to Dr. Bird, I wanted to tell you about some events that we have coming up. The first one is our Hot Flash Bash. We did this for the first time last year. It was a lot of fun and also very educational. This is an event that's focused on women's health. This year we're doing it at the Mad Water Saloon in Dixon. It's next Wednesday. That's the 22nd. And we will have some social time to begin with, beverages and food. And then and some educational booths, I think, too, during that time. And then we're going to move on to the presentations and discussions with the providers that do a lot of women's health services, and that's Dr. Marcia Jones and Dr. Nancy Tran from our Women's Sexual Health Clinic, and then also Dr. Twinkle Singh from cardiology, and Pam Kapp, who is our pelvic floor therapist extraordinaire in the physical therapy department. So they'll be doing some presentations and a group discussion. Another program or event that we have coming up is our annual spring auction, our Bloom and Grow auction. And we do a virtual event, and the auction will start on May 1st and it runs through the 5th. Right now, we're still looking for donations. So if you want to donate an item or a basket full of items, if you're a baker and you want to donate a baked good, please let us know. This year's proceeds are being devoted to our children's health services, and that includes mental health services. It includes vision care, dental care, nutrition and activity programming in the schools. And so those will be the beneficiaries of the proceeds from this year's auction. And so if you want to make a donation, give us a call at the Health Foundation office, and you can help us out with that. A final event that you might want to put on your calendar is our lunch and learn about the new tax laws and how you can benefit from those and lessen your tax burdens through charitable contributions. We have some great speakers there, a couple of advisors from Edward Jones, that would be Sam Meyer and Nick LaRue. And then we also have Will Lee, who is a local attorney that does great work with estates, and also CPA Beth McFalls. I was trying to remember her name. So we have some really great experts there to answer your questions, and lunch will be provided. So we do need to have you RSVP, and those RSVPs are due by April 30th. Before we turn it back to Dr. Bird, just a quick mention to put next year's program on your calendar, and that's going to be on Thursday, May 14th. Another area where we do a really good job is in our cancer care, and so Dr. Bird's going to be talking to Dr. Ali Khan and Dr. Al Sayed about some new therapies, how that help with us better diagnose cancers and more personalize your care. And that's what's happening at the Health Foundation. I'll go ahead and give Dr. Bird the floor here.
Thanks, Sherry. Hey, Sherry, quick question before I let you go. On that Hot Flash Bash, if you're like last minute decide you want to go there, can you just walk up there, or do you have to register?
I would call ahead. Last year we were at capacity. I know we still have room available right now,
Okay.
but yeah, I would call ahead before just showing up.
Okay. All right. And was there a number you showed there in terms of calling, or?
Yes, I think so.
Okay. So we're just wanting to register, I guess. Okay.
Yep.
Very good. All right. All right. Thanks, Sherry.
You're welcome.
All right. Hey, welcome. This is Bill Bird, Chief Medical Officer here at CGH Medical Center. Thank you for taking the time to watch this broadcast. Today, we are talking all things heart related, and looking forward to having Dr. Rashid and Dr. Kiso with me to answer some heart related questions. And as always, if you happen to be watching this live and there's something that we're not asking that you're really interested in, hey, send us a shout out and we'll do our best to answer your questions. Okay, let's get Dr. Rashid and Dr. Kiso. There they are. Gentlemen, welcome.
Thank you.
Glad to have you. And just for reference, before we go forward, Dr. Rashid is our cardiologist, along with Mary Madison, who is over in Morrison, Illinois, seeing patients at our Morrison Clinic. And Dr. Kiso, as of January, Dr. Kiso was here at the mothership in Sterling up until January. Now he is over in Dixon, for the most part, seeing patients and taking care of patients at our Dixon Clinic. So, gentlemen, you're manning the far outpost for CGH. We appreciate that. And we wanted to ask you some questions about cardiology. Are you ready to rumble?
Thank you. Yes.
Okay. All right, I'm just going to kind of go back and forth with you guys, just these questions. So let me start with you, Dr. Kiso. Talk to us about the latest technology available for patients receiving cardiac stents, and perhaps even also just like in terms of CGH, what of those technologies we have here at CGH?
Thank you. There has been a lot of development in the field, and both diagnosis and treatment. So there are new diagnostic measures to refine the diagnosis and predict the outcomes more accurately, and then treatment-wise as well. Starting with treatment, the thing that is currently going is the drug-coated balloon, which we have at CGH. You see, with stents, it started with first dilating the artery with a balloon. That's the first attempt. And then people realized the artery would collapse back. You need a scaffold, so started using stents. But the stents are foreign material, and they initiate an inflammatory reaction, and that will in turn cause restenosis and re-narrowing. So we have to use other methods, and this came with the drug-coated stent. So you put chemicals on the stent that inhibit the growth of inflammatory tissue and scar. But even those had problems. So now the trend is to use a drug-coated balloon. You don't leave any stent behind. You just go in, dilate the artery, and then use a drug-coated balloon to deliver the medication to the area you need without leaving any foreign material behind. And this is particularly good for small blood vessels where it may be too high risk to put a small stent, or bifurcations, or other specific use. And also, interestingly, people who cannot take blood thinners for 6 months or a year. So after a drug-coated balloon, because you're not having a stent there, you can afford to stop the antiplatelet therapy earlier. That is a big plus. And the other modality is what we call lithotripsy, which is similar principle to the lithotripsy for urinary calculi stones. And this delivers high frequency sound waves to cause fractures in the wall of calcium inside the vessel, which makes it easier to dilate and put a stent later on. And we have that too at Olympia Field, at CGH. And in addition, we have people who are fragile with weak hearts going for major procedures. You need to support the heart. And before we use the intra-aortic balloon pump, but now we have the latest, which is the Impella device, which is basically a pump that sucks the blood from the left ventricle and sends it to the rest of the body, because the heart muscle is too weak to efficiently do that. And this can be used temporarily, tidy us over the procedure. As far as diagnosis, we have intravascular ultrasound, which we use, and this helps give you a picture of the inside of the artery and how you deployed your stent. Is it good? Do you need to do more, or is there a complication, and so on? And then on top of that came what we call OCT, and this is, we borrowed from ophthalmology actually, but it is very high frequency waves, and it gives a much clearer picture than the IVUS, and it helps for complications of stent application, and also for studying plaques and other things. And I don't want to take too long because we could speak the whole session. But the important thing is sometimes you do an angiogram and you're not sure, is this lesion significant? Shall I do a stent or should I just leave it and treat it medically? And what we do is we measure the drop in pressure across the narrowed area now, or until recently, with a pressure wire. And this is a special wire. You have to cross the lesion and then measure the pressure distal and compare to the pressure proximal. However, what's on the horizon is something which is really exciting, and that is CT angiography, and you derive the same pressure data without having to go into the artery. So you avoid problems of dissection and complications and all that. This is, of course, up and coming. There are equipment, there are CT machines that both do the CT angio and then can analyze the stenosis significance as well. So this is what's going on, and we have all these things at CGH except for the percutaneous CT angio and pressure measurement.
Yeah. Good. Well, thank you for that answer. I know for folks who are lay people, that's a lot of medical stuff thrown at you really quickly. But just know this. I think my take home as I hear that is almost every bell or whistle, along with the people that are able to use the bell and whistles to open up blood vessels in your heart and to help your heart function as well as it can in that regard, we have right here at CGH. So I think I want you to take home from all those different options that we have for patients these days. And yes, we've definitely come a long way in cardiology from back in the day when you just put a balloon in there and tried to pop it open and that would be good enough. And then even the bare metal stuff. So a lot of really good things for people who have heart issues to be able to get vessels open and keep them open.
And if I may add, CGH is now also a referral center for acute heart attacks. So we get heart attacks in the neighborhood, in the area, and they refer them to CGH to get treated.
Yeah,
so that's another plus thing for CGH.
Yeah, good point. I appreciate that's a good shout out, Dr. Kiso. Okay, so that's vessels. Let's talk valves. So there are valves in your heart as well. And Dr. Rashid, I'm going to give you a little bit of time here to talk about the latest advances in heart valve replacement, heart valve treatments. Can you speak to those for us?
Yeah, there are quite a few exciting development as far as treating the valves are concerned. In old days, the only way you can fix a valve is to cut a chest and leave a bigger scar, go inside the heart and change the valve or repair the valve manually inside. But it has been over a decade, 14, 15 years now, a major breakthrough came when the technique was developed to replace the aortic valve transcatheter based. So no cutting of the chest, the valve was accessed with the help of a catheter from the groin through the artery. It's called TAVR, transcatheter aortic valve replacement technique. Incision was small in the groin, recovery time was quite short, a couple of days, 3 days, you are home. But initially it was offered only to the people who couldn't go for the surgery, very high risk for surgery people. But over the years, we had more data. The technique got more refined. And what the data showed with the refined techniques that all across the board in terms of the risk, the people who are high risk for surgery, people who are moderate risk for the surgery, people who are low risk for surgery, the technique was found to be as good as the surgery. The recovery time was less, so it became very popular. So the new development is now it's being offered all across the board in terms of the high risk or low risk patients. There is still the age factor because this catheter-based valve replacement is a tissue valve. And younger people, they're expected to live longer, and those tissue valves can fall apart like 10, 12 years after
Okay.
it is put. So there is still, the younger people still have to go through the surgical open heart procedure for the valve replacement because they need the metallic valve.
Okay.
Right now, that valve is not available, catheter based. So that's the aortic valve. The another newer development, and it's already ready for prime time, is being offered at centers, is what we call MitraClip, edge-to-edge repair, and that's also catheter-based. You go from the groin, access the mitral valve, and clip and tie the two to the leaflet. So the mitral valve, when it's very leaky, you clip it, and that decreases the leakage. Again, minimally invasive technique. And data has shown that it cut the hospitalization from mitral valve regurgitation and heart failure up to the half. They also being tried on the tricuspid valve, the same catheter-based. Another new development is robotic-assisted valve surgeries. And this is being done at lots of bigger centers. Again, the less invasive, the incision are small, healing is faster, the trauma to the tissue in the chest is less. So these are some of the recent development as far as the valve surgery is concerned. Another technology is these tissue valves. There are more durable tissue valves which don't fall apart that fast.
Okay.
So that is being developed. And even the metallic valves, some of the newer valves are more slick, so they are not as thrombogenic. The clot doesn't form on them that easily. So the need for Coumadin treatment in a lower dose or a lower anticoagulation works. So these are some of the newer developments.
Two follow-up questions I wanted to run by you. So for the mitral valve, is that a tissue valve? And does that mean that younger people still need to have the open heart procedure for that?
Yeah, so for mitral valve surgery, there are two different issues. If the valve gets narrowed, what we call a stenosis, mitral valve stenosis. So in appropriate patients, especially younger patients, and if the valve is pliable, you can fix it with the balloon. Go up, put the balloon, and inflate the balloon and open up that narrow area. But if the valve is calcified, it won't open that easily, and they need surgery. And if it is a leaky valve, you have the MitraClip, in the right appropriate patient. But in some patients, you still have to go in and change the valve.
Okay. Does the MitraClip have like a 10 to 12 year life expectancy too, or for the MitraClip?
It's a relatively newer procedure, and there is a certain percentage of patients who will require another procedure because they start leaking again.
Okay. And then one other follow-up question. I've read a little bit lately that maybe it used to be like you wouldn't do these procedures until the patient had really bad symptoms, had like bad heart failure or was passing out or something like that. Has there been any change in terms of the recommendations of timing of having these valves replaced?
Are you talking about the MitraClip or in general?
Just in general, like the aortic valve, like so for aortic stenosis, we're like.
Oh, for the aortic stenosis.
Yeah.
Yeah, there is a debate still going on. There are clear cut. If the patient is symptomatic, no question asked, you replace the valve. The asymptomatic patient, there is a little controversy about it. There was a time when he said that asymptomatic aortic valve stenosis, the biggest danger is the surgeon, because they go in and do the surgery and they don't improve in terms of. But I think I lost. Are you still?
Oh, you're good. We can still hear you.
Oh, okay, good.
Yeah, we'll just have to call
Forgot
your.
to move this thing. Okay.
Yeah, you're good. You're
Okay.
good.
So, but now the tendency is there's some trial going on. Extremely severe aortic stenosis, severely critical aortic stenosis. Even the asymptomatic patient, we are encouraging to go for surgery.
Okay.
And some of these elderly people who are developing severe aortic stenosis, and then the thought is they are not getting any younger. The risk for surgery is going to go higher and higher as they get older. So they are also, encouraged to go for surgery.
Okay, thank you. All right, next question. This is for you, Dr. Kiso. So we do have nowadays, there are risk scoring tools that we have for patients in terms of their heart risk over the next, let's say, 10 years. We have these scoring things that are in place. What's the latest about those risk scoring tools, and trying to figure out from those tools what patients are the ones that would benefit most from some type of intensive intervention to try to prevent that first cardiac event?
Yeah, thank you. So risk scoring tools are particularly used for people for primary prevention. That is prevention before the development of manifestations of atherosclerotic. And I say that because both heart attacks and strokes. And for people who have already had manifestation of atherosclerotic disease, you have to hit them hard and lower their cholesterol. There is no question. But for the people who are asymptomatic between the ages of 40 to 70, and then you do a risk stratification, and the risk shows them in one of a number of groups, then you have to act accordingly. So you take into consideration age, sex, race, blood pressure, cholesterol, diabetes, all these factors, and come up with the risk of having manifestation of atherosclerotic cardiovascular disease in the next 10 years. So those who have a rate of 5% in the next 10 years, these are the very low rate. These probably, of course, you use diet with everybody, but these are the ones that you use diet and lifestyle modification only. Then we come to the group between 5% and 7.5. So these are the mild group, and these again, you probably want to just keep them with lifestyle modification. Then when we come to the intermediate group, which is the 7.5 to less than 20, then these are the guys you want to hit them and lower their LDL to ideally below 70. And if they have high risk manifestations like severe diabetes or LDL more than 190, then you want to give them more than 55. So the risk scores, what they do is they help rationalize your treatment, because people sometimes, especially in the low risk, they feel healthy, they're reluctant to take any medications, especially medications which causes side effects, and it becomes a vicious circle.
Yeah.
And what's now being used more is the coronary calcium score, which tells you that there is a process of inflammation going in the coronary arteries, and the body is healing it by depositing calcium. The trick is you don't know whether this calcium is encroaching on the lumen and interfering with the blood flow, or is it just all on the outside?
Yeah.
And
so let me throw that question to Dr. Rashid here as far as that goes. So when you think about, so Dr. Kiso is talking about you have these different levels of risk. What levels of risk do you typically suggest, or will you suggest to patients that, like, hey, there is a calcium scoring CT scan that we can do to look into that? What are those patients that you would typically move in that direction, Dr. Rashid?
So what you have here, as Dr. Kiso talked about, that you throw them the numbers into the figure, and you come up with a 10-year risk. So 5% or under are low risk, and 20% or above are high risk. So no question asked, you are going to get aggressive lipid lowering and other risk reduction. Then there is this moderate category, which is 7.5 to 20%. So this is the category, where the calcium scoring is very helpful. And remember, these are the people who are asymptomatic. They're 40 to 75-year-old age range. They do not have diabetes. They do not have any previous history of coronary artery disease like heart attack, stenting. So these are asymptomatic patients, moderate risk. Their 10-year ischemic event risk is 7.5 to 50%, 7.5 to 20%. So this is the best. You do the calcium scoring, by the CT scan, and if if it is 0, then they're very low risk. You do just the general risk reduction. If it is above 100 or 100 to 300, they definitely need, or above 100, they definitely, you favor more aggressive, like a statin or lipid lowering. Between 0 to 100 is again is a bit of a controversial area, but if they have other risk enhancer, then you favor them to treat with more aggressively with the statin or lipid lowering.
Okay. Yeah, and I think the take home here is, like, if you're kind of in the middle, you might be the patient that Dr. Kiso or Rashid would say, I think we might want to just see how much calcium is building up, if any. And then they can take it from there in terms of with you to decide if, based upon that, you need perhaps some more aggressive intervention. So speaking of cholesterol lowering, Dr. Kiso, you already mentioned that for most patients who have high risk or who already have cardiac disease, you're looking for an LDL cholesterol of 70 or less. That's LDL's bad cholesterol. I guess I wanted to kind of move along also, and I'm just going to throw this one to you again, Dr. Rashid. We've heard, for decades now, there are statins, or cholesterol lowering medications that a lot of us take. Are there any other cholesterol medications on the market right now that you recommend for certain patients to make sure that whether they have heart disease or you're very concerned about them getting heart disease, you're prescribing these days?
Like you said, the statins, like atorvastatin or rosuvastatin, they are still the bedrock for the treatment for hypercholesterolemia. However, there are some patients who really need to have their cholesterol lowered, and the statins are not cutting it. And there are patients who don't tolerate. So has been very exciting, what we call it PCSK9 inhibitors. They are very effective, like Repatha or Praluent, and it has been around for about a decade now. And there is outcome data also that they reduce the morbidity and mortality. And among those in the same group, the PCSK9 inhibitors group, there is a relatively newer, we call it Leqvio or inclisiran. The advantage of this new is it's only twice a year, every 6 months. So that's for lots of patients, that's very attractive.
Yeah.
In terms of compliance, they get a shot and they are done for 6 months. So that's an exciting new development. In the tablet form, there is a newer, we call it bempedoic acid tablets. It's not quite as effective as PCSK9, but it's a tablet form, and if you combine it with Zetia or ezetimibe, and there's actually a combination tablet, it does reduce about 35 to 40% LDL. So these are some of the newer lipid lowering agents.
Yeah, and one of the take home that I'm hearing in this is that I know there's a lot of patients that either they are convinced or you have decided that they are not a good fit for taking statins. And so now there are some drugs out there, if you're intolerant of statins, that can still get your cholesterol in a much better place in terms of preventing cardiac disease.
Yes, absolutely.
Yeah. I'm going to switch gears from cholesterol and cholesterol medications. And for the sake of time, Dr. Kiso, I want to ask you one more question about pacemakers and defibrillators and those type of things. What are the patients that need defibrillators and or pacemakers, Dr. Kiso?
Well, pacemakers were introduced to treat slow heart rate, basically from complete heart block, where the top of the heart is not communicating with the bottom of the heart adequately, and that's why you have these very slow heart rates. And then they developed into a functional basis, functional use for people with heart failure. With heart failure and certain electrical changes in the heart, we call them bundle branch block, the electricity is not flowing simultaneously to both ventricles, so they will be dysynchronized. So one contracts before the other, and that's inefficient. So now we have pacemakers which pace the two ventricles at the same time, so they act in unison as one unit. So that's that. As far as defibrillators, they are for purposes of treating dangerous heart rhythms, basically ventricular fibrillation, where the heart becomes chaotic and there is no actual output, and then the ventricular tachycardia. They do that by delivering an electric shock that will stop the heart, and then the heart will resume its own rhythm again after the pause caused by the shock. So every defibrillator has pacemaker capabilities, but every pacemaker doesn't have defibrillator. No pacemaker has defibrillator capabilities. It's just for the slow heart rate.
Okay. All right. Very good. And one bonus question to finish things up for Dr. Rashid. Dr. Kiso talked about heart failure and that sometimes pacemakers are used to help with heart failure. There are other treatments for heart failure and medications and the like. Can you speak to some of the latest in terms of newest medications or the newest treatments that are recommended for patients who have heart failure?
I think the newest, there are 4 foundational treatment in terms of pharmacotherapy: beta blocker, what we call second ARNI, or angiotensin receptor neprilysin inhibitor like Entresto. Then we have this mineralocorticoid receptor antagonist like spironolactone. But the 4th one, and it's the newest, and there are very good outcome data, is the SGLT2 inhibitors like Jardiance or Farxiga. And the good thing is that this newest addition has decreased hospitalization with the heart failure. There is mortality improvement data, and it's being used widely now, fortunately, and we are seeing some very, very good results.
Mm-hmm.
Another good thing about that this medicine is effective in both systolic heart failure and diastolic heart failure. So this is a good addition. Another thing which is not being practiced so widely is the iron infusion. But there are some good data coming out that the people who have like systolic heart failure with reduced ejection fraction, and if they are iron deficient, so you do the blood test, they have deficiency in iron, then you send for iron infusion, and that has shown to improve their mortality.
Really? Okay, so you get their hemoglobin higher.
Even if their hemoglobin is normal, they don't have to be anemic, but their ferritin level has to be under 100. They are iron deficient.
Okay.
So our renal failure, our nephrology colleagues are very fond of infusing the iron in their patients, and of course the hematologist. but in systolic heart failure patients, this is some newer addition. We should be paying more attention to it and then look
Okay.
at the data as well. So
That's a good tip. Yeah, that's good to know. So, okay, well, we could go on. These guys could talk for hours about what they know about people, about your heart and how to help it. But we're gonna have to cap it at about 30 minutes. So, gentlemen, thank you for your time. It's been great having you, and we'll have you back sometime. And we'll talk some more. Yeah, but you see below at the bottom of your screen there how you can get a hold of Dr. Kiso or Dr. Rashid if you need to see them as a cardiology patient. They are taking on new patients, and be glad to see you. So, gentlemen, thank you so much for your time.
Thank you.
thank you. Thank you. I appreciate it.
All right. So before I wrap things up, I know I have a few shout outs. I want to, first of all, I wanted to congratulate Sherry Gascoigne for being the April Employee of the Month. So congratulations to Sherry. Sherry works in our neurology department at the clinic. And yes, next month, we're going to be talking about cancer care, and we're going to have both Dr. Ali Khan and Dr. Al Sayed here to talk about some cancer questions. And of course, if you have cancer questions, you could send those in as well. So, oh, there I am again. Hey, thank you for taking the time to watch this. And as always, if you found this helpful or thought there might be parts of this that others might enjoy watching, please feel free to pass this around to others. Until then, thank you for watching this. This is Bill Bird, Chief Medical Officer at CGH Medical Center. Thanks.